Okay, welcome and thank you everyone for joining us today for SLP Grand Rounds. Our presentation today is on the Pediatric Eating and Swallowing Clinical Practice Guide. We have three wonderful presenters today, Beverly Collison, Candace Larson, and Melissa LaChapelle. I'll let each of you maybe present or provide a brief background for each of yourselves. I wanted to make sure that everyone was aware that this session will be recorded, and we archive these sessions on the SLP Practice Council page on Insight. It'll take a few days for the upload to occur, so if you keep checking back, that would be great. The presentation will also be made available on the PEAS website. The presentation today will be approximately 45 minutes, followed by a question and answer period. You will be able to enter your questions into the instant messaging window. Anything else I want to say? Of course, it would be really important that everybody make sure to mute your phone lines today, mute your headsets during the presentation. I think that is about it. I'm going to pass it over now to our first presenter, Beverly Collison.
Thank you so much, Kevin, and good morning, everyone. Welcome to SLP Ground Rounds. This morning, PEAS is excited to host an exploration of the PEAS Pediatric Feeding Disorder Clinical Guide. We recognize that many on the line today have already attended the PEAS Clinical Practice Guide overview presentation. So today's round will take a closer look at swallowing and swallowing resources within the CPG. My name is Beverly Collison. I'm a speech-language pathologist. Together with Melissa LaChapelle, the AHS Provincial Practice Lead for Nutrition Services, we have the privilege of co-chairing the PEAS Standardized Practice and Education Working Group. The many resources that you will see today are the result of the commitment of the Standardized Practice and Education Multidisciplinary Working Group members that have worked hard to enhance care for infants, children, and youth. We are pleased that Candace Larson, a speech-language pathologist in Calgary, has joined us today. Throughout this presentation, we will turn to Candace to share her experiences navigating the health system as a mother of an infant with dysphagia and pediatric feeding disorder. We are excited that today's SLP Ground Rounds fall on the second day of Pediatric Feeding Disorder Awareness Month. We invite you to spread the word. Using the PEAS Pediatric Feeding Disorder Clinical Practice Guide as our foundation, this morning attendees of this Ground Rounds will learn more about screening for pediatric feeding disorder and dysphagia, assessment and diagnosis of pediatric feeding disorder and dysphagia, and pediatric feeding disorder and dysphagia management and resources. A little bit of background: the Pediatric Eating and Swallowing, or PEAS, project is a provincial quality improvement initiative. Its purpose is to develop a clinical pathway to standardize and improve the care of children with pediatric feeding disorder as defined by Godet and his colleagues in the Journal of Pediatric Gastroenterology and Nutrition in late 2019. For this phase of the project, our target population is children in the ambulatory care setting, so PEAS has focused many of our resources on outpatient and community care. That being said, you may find that many of the PEAS resources may also be applied or adapted for other care settings. This project was inspired by leadership from the Alberta Children's Hospital, Glenrose, and Stollery, recognizing that there was a need for quality improvement in supporting infants, children, and youth with feeding and swallowing concerns. It began with 2 World Cafes conducted in northern and southern Alberta, with the goal of determining from multiple stakeholders, and this included patients, families, dietitians, nurses, pharmacists, social workers, administrators, amongst others, what was currently working and what was not working in the care of infants and children. The concerns shared were vast, and they included confusion related to role clarity, communication, access to services, gaps in knowledge, goal setting, and providing patient and family-centered care. These are some of the examples of the issues that were expressed by families and care providers. I'm pleased to turn it over to Candace, who will reflect on this feedback with us as she introduces us to the start of her own personal journey. Welcome, Candace.
Thanks, Beverly. I wanted to thank Melissa and Beverly for inviting me to share my experiences today navigating the feeding world. I have personal experience managing the feeding difficulties of one of my sons, and I really identify with the common themes that came up in the World Cafe. William's feeding development at home was not well supported, and it's been really challenging trying to navigate the system. To tell you a bit about myself and my twins, they were born 3.5 months early, and they weighed 1.5 and 2 pounds at birth. William in particular had a very rocky NICU stay. He was intubated for 42 days. He had infections, blood transfusions, a few surgeries, and he ended up having severe reflux, which caused oral aversion. He came home after 4.5 months with home oxygen. He was NG tube fed, and he was only taking 1 ml by syringe orally. We worked hard to build his feeding skills and wean him from his NG, and he came off the tube at 5 months corrected. He's now 3, and he continues to have feeding delays, unfortunately. His weight gain hasn't been great since we stopped bottles, so we're still working away at improving his feeding. However, in spite of his feeding difficulties, he has a good relationship with food and will try almost any food put in front of him. His challenges are more around oral motor skills and progressing to more challenging textures. To complicate matters a little bit, we recently learned that he aspirates thin fluids when he's sick, which put him in the hospital a few times last year with pneumonia.
Thank you, Candace. Pediatric feeding disorder affects 1 in 37 children. Infants like William often fall through the cracks. Yet, through collaborative care and the proper support, pediatric feeding disorder and dysphagia can be well regulated and treated. As we move through our learning objectives this morning, we will continually reference the Pediatric Feeding Disorder Practice Guide and show you where you can find explanations and some tables and lots of resources. Melissa LaChapelle will actually walk through it with us when she discusses management. Let's start with the diagnostic criteria for pediatric feeding disorder. Pediatric feeding disorder is a disturbance in oral intake of nutrients inappropriate for age, lasting at least 2 weeks and associated with one or more of the following medical, nutritional, feeding skill, and psychosocial dysfunction in the absence of the cognitive processes consistent with eating disorders and pattern of oral intake that is not due to a lack of food or congruent with cultural norms. We urge you to review the CPG to review the full inclusion criteria for pediatric feeding disorder. Dysphagia is the term used to refer to a disruption, impairment, or disorder of the process of deglutition, which is the action or process of swallowing, that compromises the safety, efficiency, or adequacy of oral intake of nutrients. Dysphagia may involve the oral cavity, pharynx, or esophagus, and affect the oral, pharyngeal, and/or esophageal phases of swallowing. It affects an infant, child, or youth's ability to safely suck, drink, chew, eat, control their saliva, take medication, or protect their airway. Over the past 20 years, there has been an increased recognition of the complex interface between pediatric feeding disorder and swallowing impairments in infants and children. As we saw, pediatric feeding disorder is a multi-criteria disorder. Within its criteria are swallowing considerations. That is, under the medical dysfunction domain, pediatric feeding disorder includes aspiration or recurrent aspiration pneumonitis. Swallowing impairments, on the other hand, are not specific to the process of deglutition, are more specific to the process of deglutition. Hence, all children with swallowing impairments have pediatric feeding disorder, but not all children with pediatric feeding disorder necessarily have swallowing impairments. Effective management of children with pediatric feeding disorder and dysphagia depends on the expertise of many specialists working independently and as a team. Each professional brings expertise that is useful in the solution of these complex diagnoses. Most importantly, parents and caregivers, as Candace reminds us, are integral members of the team. As we move into screening, assessment, diagnoses, and intervention, AXLPA standards remind speech-language pathologists of our clinical responsibilities and liabilities in this area. We start with screening. Why do we screen for pediatric feeding disorder? Screening has been shown to promote early identification of risk of having pediatric feeding disorder. Furthermore, a comprehensive screening tool can present education about feeding milestones, provide a referral method for a comprehensive assessment, and provide a platform for parents to discuss concerns with a healthcare professional. Why do we screen for swallowing impairment? Screening for swallowing impairment allows us to determine aspiration risk, improve awareness of swallowing risks and impact on hydration and nutrition, ascertain the need for a comprehensive assessment to determine anatomical or physiological abnormality, and provide a referral method for a comprehensive assessment. As a validated screening tool, PEAS recommends the Feeding Matters Infant and Child Feeding Questionnaire. This remarkable online tool is available on the PEAS website for both families and healthcare providers. It leads families and health professionals through a series of questions that use smart logic to arrive at a risk statement for pediatric feeding disorder. As families and healthcare providers work through the questions, each provides education about typical and atypical feeding and eating development and swallowing considerations. This questionnaire serves as a robust platform to start a conversation with families' care providers, such as their family physician. After completing the Feeding Matters Infant and Child Feeding Questionnaire on the website, P's can return and click on Find Services to locate services in Alberta. We encourage you to check out a recently published article in the Journal of Pediatrics that describes the psychometric properties of the Infant and Child Feeding Questionnaire. You can find it on the P's website under Community of Practice, and Melissa will take you there later this morning. Candace, we turn to you now to share your thoughts about screening.
Thanks, Beverly. So my experience with screening and the boys is that we were often asked about their eating, but not necessarily in great detail. The questions were usually, are they eating well, and are they eating a variety of foods? But I was never quite sure what well meant. We were screened by our pediatrician and by a hospital clinic that was supporting us. When I had the boys, my only experience with pediatric feeding was the few sessions we spent on it in grad school, and that was 7 years prior, so my knowledge at the time was really minimal. Looking back, I think I was so positive about William's early successes with bottle feeding and purees that it took me a while to realize that more advanced textures weren't going well. A few months after dropping bottles and moving solely onto solids, William started falling off his growth curve. We were referred to the dietitian to determine if he was getting enough calories, and it seemed like he was, which was pretty confusing. We were coached on offering high-calorie foods, but it never really seemed to make a big difference for William. I don't know if it's because I was an SLP and people assumed that I was knowledgeable about feeding, but there was very little parent education on typical feeding development and the oral motor skills and textures that you would expect at each stage. I've looked through the Feeding Matters questionnaire, and I wish that would have been a part of our screenings. I like how for each question it describes what a child that age should typically be doing, so it educates you as you go along. I also think it would have flagged William for further swallowing assessment, as his reflux was disguising his ongoing swallowing issues.
Hello? Hi.
Sorry, I'm just going to interrupt briefly to remind everyone to mute their telephone lines, please. Thanks.
That sounds great. Yeah, I will do that. So I'll just pop up and you're going to leave it about, I'll just meet you there, or?
All right, that didn't work.
We can just let Kevin for the person who's not muted and mute their mic.
Thank you.
So.
Yes. We'll try that one.
Thanks so much, Kevin and Julie, and thank you, Candace. It's absolutely critical to this quality improvement work that the tools that are recommended by health professionals are endorsed by you, Candace, and other families who have faced similar challenges. With this in mind, we will now turn to assessment and diagnosis of pediatric feeding disorder and dysphagia. Health professionals assess in order to identify, describe, and diagnose. For pediatric feeding disorder, this includes impairments in body structure and function affecting feeding and swallowing, including affected oral and swallowing phases, limitations in activity and participation, including the impact on overall health, on the child's ability to participate in routine activities, psychosocial, environmental, or personal factors that serve as barriers to or facilitators to successful nutritional intake and mealtime participation, comorbid deficits or conditions such as developmental disabilities or syndromes, and of course the impact of feeding and swallowing impairments on the quality of life of the child and family. Our assessment provides the essential basis for a diagnosis, a statement of severity, a statement of prognosis. This is important to help manage intervention resources, and it promotes accountability. The development of a comprehensive management plan, facilitating the inclusion of all relevant healthcare professionals, and achieving the best possible safety and relational feeding outcomes for the child. An initial assessment of feeding includes considerations within the medical, nutritional, feeding skill, and psychosocial health domains as laid out by Gaudet and his colleagues. Due to the interactions across these domains, impairment in one domain can lead to dysfunction in any of the others. To guide a thorough feeding assessment, answer the following 5 questions and consider the 4 health domains that we just saw: medical, nutrition, and hydration, feeding skill, and psychosocial. Within each question, is the current method of feeding safe? Is the feeding adequate? Is feeding a positive experience for child and parent? Is feeding appropriate for the child's developmental capacity? And is feeding efficient? These 5 questions are listed in order of priority in order to identify, diagnose, and address feeding problems. A clinical evaluation of swallowing is the first step in determining the presence or absence of a swallowing disorder. To guide a thorough swallowing assessment, PEAS identifies one primary question which encompasses 3 dynamic assessment elements. Is swallowing safe? That is, are there signs and symptoms of decreased airway protection? Can physiological and respiratory stability improve safe oral feeding? And can compensatory strategies or diet modifications improve safe oral feeding? Instrumental evaluation is conducted following a clinical evaluation when further information is needed to determine the nature of the swallowing disorder. Instrumental evaluation can also help to determine if swallowing safety can be improved by modifying food textures, liquid consistencies, or positioning. The 2 most commonly used instrumental evaluations of swallowing for the pediatric population are video fluoroscopic swallowing study, VFSS, and fiber optic endoscopic evaluation of swallowing, FEES. VFSS and FEES can be complementary and augmentative. Both tests provide information about modifications that can be made to enhance swallow safety and allow an infant or child to continue eating by mouth. Determining the appropriate procedure to use depends on what needs to be visualized and which procedure will be best tolerated by the child. Within the CPG, you will find indications and contraindications of both of these assessments, as well as their respective advantages and disadvantages. A reminder of what an instrumental evaluation of swallowing is and what it is not. An instrumental swallowing assessment is a dynamic evaluation of coordination, timing, and safety of swallowing function. It is not pass-fail based on aspiration and should never be used only to assess for the presence or absence of aspiration. excuse me, as the science advances, so do the tools. The baby VFSS IMP is a new and novel tool that promotes standardized assessment of physiologic swallowing impairment using visual observations of VFSS recordings in bottle-fed babies. The content and construct validity of this tool have been established. It holds promise for the identification of physiologically based treatments for dysphagia intervention, aiding in guiding clinical decision-making regarding enteral feeding, and tracking the trajectory of swallowing disorders through development in young children. Candace, we turn to you now to share your assessment experiences with William.
Thanks, Beverly. So I requested more assessment of William's feeding skills at one point when I noticed that he was lagging behind his twin and also coughing a lot when drinking out of cups. I remember the assessment being a bit jargony, feeding jargon that I wasn't super familiar with at the time, and I had a hard time understanding where William was falling behind. I find it really hard to concentrate at these appointments. I recently did a course where they talked about how parents' cognitive abilities decline as their stress increases, and I really identify with that. With so many visits for William, my stress was sky high even before getting in the door because of the difficulty of packing up 2 babies and traveling across the city. I would have loved if someone would have offered to help me take notes or walked me through some handouts so I would have something to look at later around his feeding development. I later found out that the therapist thought William's feeding was quite delayed, but I honestly don't remember her stating this clearly or providing a diagnostic label at the time. I left the appointment thinking, so I guess his feeding is okay. In terms of an assessment to rule out dysphagia, I had to push for months for a referral, and it turned out William was having swallowing difficulties that were confirmed by a VFSS. For years, people assured me it was just his bad preemie lungs or his reflux that was causing the pneumonia and choking episodes. You should never be happy when your child is diagnosed with swallowing problems, but I felt so vindicated. It really helped me to understand William better, and I just wish it could have been done sooner and saved us a few hospitalizations.
Thank you, Candace. As Candace
Hi, Beverly. It's Kevin. I'm not sure if your phone line is muted or not.
Hi there, can you hear me now?
Yes.
Okay, great. I think I must have dropped off.
Yeah.
Thank
but you're
you.
Back.
I'm back.
Yeah.
Thank you, Candace. As Candace illustrates, diagnosing requires the healthcare provider to identify and label a condition that the practitioner is responsible for treating. Speech-language pathologists are responsible for diagnosing pediatric feeding disorder and dysphagia. Coding systems are used to differentiate diagnoses. In Alberta, the ICD-10, and that's the World Health Organization's coding system, is used by many disciplines, including speech-language pathologists. Its importance is that accurate and consistent application of diagnostic codes yields valid and reliable data on health utilization, costs, quality improvement, and clinical and research outcomes. Just last month, the U.S. Centers for Disease Control and Prevention, that's the CDC, officially approved pediatric feeding disorder to be a standalone diagnostic code in the next edition of the ICD, which will be released on October 1st, 2021. This will be a new R code. This marks pediatric feeding disorder as a condition that has been for too long dismissed as a symptom of a different problem. It's my pleasure to welcome Melissa LaChapelle now to guide us through pediatric feeding disorder and dysphagia management and resources.
Good morning, everyone. Thanks, Beverly. I would now like to give you a high-level overview of the management section of the clinical practice guide, highlighting some of the key areas that may apply to your practice this morning. Once we have assessed and identified a pediatric feeding disorder with or without dysphagia, we can facilitate goal setting with the child and family. Interventions to achieve therapy goals will be more successful when planned in collaboration with children and caregivers and members of the multidisciplinary team. We want to acknowledge that not all members of the multidisciplinary team are presenting this information today, but we have collaboratively developed this content within our multidisciplinary working group and want to thank them for their contributions. Management of a pediatric feeding disorder is multifaceted and should be grounded in evidence-based practice, as you'll find in the CPG. In the CPG, you'll find that there is strong emphasis on patient safety as the first priority before engaging in oral feeding. We have identified 8 key areas in the CPG that all play a role in the management of a pediatric feeding disorder, which we will review on the website. These areas include medical stability, facilitating safe swallowing, optimizing nutrition, appropriate seating and positioning, feeding skill development, feeding environments and routine, sensory processing considerations, and oral hygiene. So I will now move us to the website. Oops. So when we get to the website, in order to find the CPG, we would advise you to go to the For Providers section. And then you have 2 options to access it, either going on the left-hand side of the toolbar or going to the Read More section. And both will take you to the same place. And so on the left-hand side, we do have our different sections, key headers for the CPG, and as well a PDF version. But today we'll jump right into the oral feeding section. And we'll be looking at medical stability first. Management of all medical diagnoses is crucial to the success of other interventions. If feeds are initiated prematurely, a pediatric feeding disorder can be exacerbated. Oral feeding progress can change from feed to feed and day to day, which requires routine monitoring and reassessment as depicted in the pediatric feeding care cycle we showed in previous slides. In children who have been medically unstable or non-oral for a considerable period of time, confirmation of medical stability by a physician for appropriate initiation of oral feeds is recommended. And we have listed a number of considerations in the CPG that suggest medical stability, which are listed here. A primary goal of PFD management is to facilitate a safe swallow while optimizing oral intake. Following the identification of dysphagia, an interdisciplinary team approach is best practice to determine appropriate management strategies. Strategies to support safe swallowing function should prioritize feeding safety, intake adequacy, facilitating a positive feeding experience, supporting development, and feed efficiency certainly come into play once safe feeding is established. And reassessment is recommended whenever a child has a significant change to their health, development, medical status, or after airway surgery or extubation. Dysphagia intervention can include rehabilitation, compensation strategies, or a combination. We want to provide medications in a format that is safe for a child with dysphagia. Modifying a medicine's format may alter its effectiveness or stability, as well as its taste, texture, and overall acceptability. So consultation with pharmacy can improve administration and palatability. And we have several reference links, as you'll find throughout the CPG. In particular, I would want to draw your eye to the My Health Alberta site, Helping Children Take Medicine, as this gives us tips and tools to help children take medicine more efficiently. As mentioned earlier, feeding and swallowing interventions can include both rehabilitation and compensatory strategies. Rehabilitation strategies are based on motor learning principles of neuroplasticity, and repetition of functional behaviors, for example, interventions using food or fluid. Compensatory strategies include some of those listed here. So when we move into our pacing section, we can see that pacing will slow the rate, which encourages suck, swallow, breathe coordination and establish normal respiration. We have texture modification and progression to a moist, cohesive consistency to support oral manipulation and reduce choking risk. And this is a fairly large section in the CPG with multiple tables embedded and related appendices, so we will come back to it in a minute. Modifying the positioning to maximize control of muscles for feeding, using alternative equipment to modify the method of bolus delivery, such as the use of slow flow nipples, straws, cups, and spoons. And here we have a direct link to our feeding equipment appendix, which I encourage you to investigate further. Hydration and nutrition may also be impacted and need support through nutrition interventions, which may include tube feeding to enhance nutritional intake. And so here we just have some early introduction to that section. When looking at compensatory strategies and rehabilitation techniques, we are in the process of kind of considering reorganizing this section just to better delineate the differences between them. Rehabilitation can improve anatomy and physiology. However, there is some limited evidence in pediatrics and a weak positive effect for motor learning when used alone. Compensatory strategies are unlikely to improve physiology, but we really want them to be responsive, and we want to wean strategies as skills progress, with a goal to decrease reliance on that strategy long term. And so our evidence-based recommendation from PEAS would be to use a combination of rehabilitation interventions and compensatory strategies. As we move through the CPG, one table I wanted to bring your attention to, once we scroll down, is our thickener section. So this was really at the request of clinicians, where we've identified multiple thickeners, some of their product information, and a key component would be their recommended use. So we've identified some specific information around age recommendations. I'll now move us into nutrition management. So all children with a pediatric feeding disorder benefit from a nutrition assessment, as they are at greater risk of malnutrition and nutrition deficiencies. Oral nutrition support strategies to optimize food, fluid, and nutrient intake are often needed to support adequate growth and meet nutrition needs for optimal health. Strategies may vary based on the child's age, medical condition, current skill set, psychosocial factors, and current intake. And we also want to reflect the individual taste, culture, budget, and lifestyle of the child and family. In the CPG, you will find recommendations for breastfed and formula-fed infants, strategies to support children of all ages, and we also dive into supporting a healthy meal pattern, addressing limited food variety, and ways to advance food textures. If oral nutrition support is ineffective, enteral nutrition support may be considered as an additional or alternative therapeutic management strategy. In the CPG, you will find useful tools, such as this algorithm to support decision-making, where first we consider whether the child is safe for any oral intake, and then consider what our options are to optimize oral nutrition support, such as offering a high-protein calorie diet, texture modification with or without thick fluids, oral nutrition supplements, etc. So we have included some suggested monitoring as well for reassessment of intake. If the child is not safe for oral intake, we would then refer to the enteral section of the CPG to support decision-making with the family. And sometimes a combination of oral and enteral feeds is needed to support the child to grow, improve their health status, and facilitate safer swallowing and building stronger feeding skills. In the CPG, we have outlined when enteral feed should be considered, focusing on airway protection, intestinal function, and have outlined parameters for inadequate oral intake that require intervention. As we move into seating and positioning, I want to acknowledge our OT and PT partners who helped develop this section of the CPG. It really does take a multidisciplinary team, and we want to acknowledge them since they aren't presenting today. Appropriate positioning of the infant or child is essential for effective, efficient, and safe feeding for suck, swallow, breathe coordination. And positioning intervention will need to be provided to those children who are disorganized, require support to maintain a midline position, and may not have achieved or will not achieve functional sitting. Safe feeding may be facilitated by commercially available or specialized equipment for which more detail can be found in the CPG. And so we do have some really great tables and graphics to support this section of the CPG. As we move into feeding skill development, we really emphasize in the CPG that feeding is a neurodevelopmental skill and relational process. And we need to consider that when looking at strategies for feeding skill development. Children with delayed or disordered oral reflexes will need individualized treatment techniques to facilitate their oral motor skill development. Promoting early recognition and response to cues, intervening to prevent distress and disengagement, and managing the feeding opportunities so that they're manageable, enjoyable, and successful, and an overall positive experience are reviewed in this section. And so I encourage you to navigate this section. With this section, there are a number of resources associated with it in our For Families section, when you go to oral feeding, and then when you go to educational materials. So a lot of the content does cross over into these great education materials. With regards to feeding environments and routines, I think that we can all appreciate that mealtime is not just a time for eating, but a time for relationship building, exploring food, learning mealtime manners, and developing social skills. So within this section, we really emphasize a predictable mealtime routine and environment can help a child learn the difference between hunger and satiation and may help with self-regulation. A child's ability to participate fully in the mealtime routine can be influenced by a range of factors, including the physical and sensory environments. Examples may include talking about today's events, having a clear start and end to the meal with transitions, minimizing distracting stimuli, etc. And so there's a lot of good information in this section. Sorry, trying to jump through here. Supporting a positive feeding relationship with positive mealtime interactions does start with cue recognition, supporting oral motor development, providing feedback on the child's efforts and successes, and limiting the use of rewards and avoidance of force feeding. Parents should be encouraged to use the division of responsibility, to trust their child's appetite and offer appropriate choices and provide foods that are in keeping with their child's sensory preferences and oral motor capabilities. Our sensory processing section really emphasizes that each child has unique sensory processing needs and regulation abilities. So how a child responds to sensory information during mealtimes may impact their feeding development and mealtime experiences. Achieving a calm and alert state is a first step, and adjustments to accommodate sensory needs are more likely to result in a positive feeding experience. The CPG provides strategies for food play, steps to discovery, oral desensitization, preparation for meals, and supporting mealtime routines and environments while supporting the sensory preferences of the child. So there's a lot of great information in here I encourage you to check out, and a lot of linked resources within as well. As we transition to enteral feeding, I want to acknowledge the importance of oral hygiene and dental health. It's an important part of management, as children with dysphagia, cognitive impairments, and enteral feeding are at greater risk of poor oral hygiene, which can lead to aspiration pneumonia. So now I'm just going to scroll down and take us into a brief overview of the enteral section. So when oral feeding is no longer safe, possible, or adequate, collaborative decision-making between the interdisciplinary team and family is recommended to determine the optimal feeding route, type, and duration of enteral feeding. Oral feeding or stimulation should continue to be offered if safe and appropriate. And there are a number of great tools in here that I encourage you to review, and in particular, we'll just discuss Figure 10. So although controversial, research suggests that children have better feeding-related outcomes when we're cognizant of how long they've had their tube. The working group collaborated with physicians to create this decision-making tree, which emphasizes that nasoenteric tubes are intended to be temporary. So consideration of gastrostomy insertion is highly recommended when enteral feeding is expected to extend beyond 4 to 12 weeks. Physicians and the interdisciplinary team should provide information and guidance to parents and children as appropriate early in the treatment process to assist and support their decision-making. And as there are risks to both long-term nasogastric tube use and gastrostomy tube insertion, it is essential to consider, in collaboration with the parents, the child's medical needs, overall health, ability to safely consume oral intake, and recent progress with feeding skills, and to together determine the best option for the child in the short term and the long term as applicable. And just to wrap up our management section, I just want to give some attention to the transition from enteral to oral feeding, and that this should really be considered from the time enteral feeds are initiated. Setting a clear platform from the outset prevents enteral tubes from being used longer than required. Supporting safe intake starts with supporting eating skills, and this really circles us back to the assessment of readiness for oral intake with a safe swallow. From there, we can collaboratively set achievable goals and consider the oral management strategies set out in the CPG. As we're looking to prepare for weaning, we want to recognize that the approach to weaning enteral feeds will be different for each child, and there is no consensus on the ideal model for weaning, as this is child-specific. The Graz model, or various adaptations of its principles, is frequently cited in the literature and proposes that the steps to weaning encompass hunger provocation, supporting eating skills, exposure to food, reducing stress, acknowledging and responding to the child's cues, and avoiding force feeding. And at each stage in the transition process, it is important to identify a limited number of achievable, developmentally appropriate, and measurable goals. Permanent removal of a feeding tube may be considered when the child is clinically stable and has safe and adequate oral intake in order to grow appropriately and meet other nutrition parameters. And so I will now ask Candace back to talk with us about her experience with Williams feeding interventions and management.
Thanks, Melissa. So Williams feeding supports were really sparse once we left the NICU and enormously confusing. In the NICU, we had a web of support around us. We had an occupational therapist, nurse practitioners who were extremely knowledgeable with feeding, trained nurses, and a breastfeeding consultant. When we left the NICU, we had a team of home care nurses for 4 months, and they were a huge help to us. However, we only saw an OT who specialized in feeding every 4 to 6 weeks as a part of our oxygen clinic visits. I was so confused about how supports were structured, and I kept asking people, what happens when William is not on oxygen anymore? Who will be supporting his feeding? And no one could give me a straight answer. Our nursing home support was ending, and William was getting close to coming off oxygen, and I was starting to panic. It boggled my brain that an infant with enormous neurodevelopmental potential was only being seen for consultation every 4 to 6 weeks. I know of kids with mild articulation delays who receive more robust and frequent therapy supports. I was terrified of sliding down a slope into long-term tube dependency because it seemed like once William came off oxygen, we might not get any support with his oral feeding skills. I panicked and pushed for a tube wean. I remember telling my mom, we need to get him out of the system because it's not supporting him. I just couldn't believe how little support there was for a child with feeding issues. Coming from the worlds of PUF and FSCD, it was staggering to me that feeding, a skill that literally supports health and development, was so overlooked. Everything seemed focused on safety, tube management, and calorie intake, and no one seemed to be helping us progress William's oral feeding skills. I so badly wanted a multidisciplinary team that coordinated with each other and a set of well-defined goals to help us move forward. Everyone seemed to favor a wait-and-see approach that seemed to rely on William's feeding skills passively improving to the point where his tube could come out. I had no faith in that plan, but there was never a clear discussion around it, so I just had to come up with my own plan. That being said, seeing everything that the PEAS project has accomplished already is so exciting, and I know that it will have a huge impact on feeding supports for kids in Alberta. So there are a lot of great resources on the PEAS website that I wish could have been a part of William's feeding plan. There's an oral feeding care plan. So this is a great document to ensure the child's feeding needs are clearly communicated across settings. There's also a collaborative goal wheel. This is a really important document that you can use to set out the main goals and detail what steps are being taken to achieve them. And there's also a swallowing risk document that you can share with parents or other health professionals to help determine if a child is at risk of aspiration.
Thank you, Candace, for sharing your journey with us and your insight into management and tools. I think your story is testament to the importance of supporting a family throughout their entire journey, which may include transitions in care. Monitoring, evaluation, and reassessment are key aspects in meeting family goals. And as one support or service comes to an end, we need to ensure that there is coordination of care and additional support for the journey ahead. This is crucial to the success of meeting those family goals. In the CPG, you will find some information on transitioning home on enteral feeds, transitions between pediatric and adult services, and how the tools can be used. As we wrap up, I want to bring you to the PEAS community of practice. You can join via the website and click Join the Community. We encourage you to share, learn, and engage with others. I would like to take this opportunity to thank Candace for sharing her and William's story with us. We really appreciate your time and commitment to improving the care for Albertan families. I would like to thank Julie Evans and Kevin Lindland for inviting Beverly and I and Candace to present today. I would also like to thank the countless contributions from our project management team, Vanessa Stanke throughout this entire process, and Rochelle Van Vliet for supporting the development of the CPG. And I would also like to thank members of our Standardized Practice and Education Working Group, and countless others, in fact. The CPG and so many of the resources you will find on the PEAS website are truly a labor of love and devotion from this group and many others. And I will now invite Beverly to close with a final acknowledgement.
Thank you, Melissa. Thank you, Candace. In July, we lost our brilliant colleague and loyal friend, Wendy Johansson, to cancer. Wendy was an integral member of the PEAS working groups. She worked tirelessly on 2 committees, Standardized Practice and Education and roles in implementation. When you review the CPG, you will notice that Wendy's perfectionist touch imbues the clinical and instrumental swallowing sections. We strive to continue to support families in the compassionate way that Wendy modeled for us. We want to thank you all for joining us today. Candace, Melissa, and I are happy to answer your questions.
Thank you so much, guys. For the audience, if you'd like to ask questions through the instant message window, that would be great, or by phone. Any questions? Yeah.
So how's William doing now? He's doing really well. He hasn't had any more aspiration pneumonia since we discovered that he was aspirating thin fluids when he's sick. So he drinks out of one specific cup now that's safe for him to drink out of. And otherwise, he's doing well. Like, we're working on getting him to be a bit more successful with more challenging textures. But yeah, I feel like he's moving forward and he's doing well. And he likes food. Like meal times aren't a fight or anything. It's just more, I have to be really cognizant of the texture of food so that he can eat enough of it to support his growth. But yeah, he's a really happy little guy. And I feel like overall we're moving forward now.
Right. There's a question from Bobby Williamson just asking about how widely shared this information has been, particularly, with physician groups and other stakeholders.
Maybe Vanessa, would you mind fielding that question about the socialization of peas?
Yeah, for sure. So just acknowledging that there's definitely gaps in getting this information out takes time. Right now, we've really been focusing on, the website was launched this spring, and we've been providing training to staff within AHS, including physicians who've been invited, but we're hoping to help just snowball that and keep sharing the information. So you helping us out by sharing that with the community pediatricians is wonderful. Please keep doing that. We have grand rounds scheduled for June at the Stollery, so there's another mechanism. We've been invited to share at conferences nationally and internationally, so hopefully the word continues to spread. I hope that answers your question, and Bev, Melissa, feel free to chime in as well.
Yeah, it's Melissa. ICS has, right now, we're in those early phases of implementation and socialization, and so I think we are asking you to also share the word, share the website, share the information with your local teams, and encourage and support those discussions. And I think with the Innovative Learning Collaborative, those sessions coming up, and the evaluation that's also ongoing, that's going to shed light on some of the information in the CPG, in particular the tube times, so that we can look at that quality improvement aspect.
Just to add a little bit from William's story, William had an NG for 9 months. So this information was a bit of a surprise to me. So I think, yeah, it's still not really out in the community in Calgary anyways.
All right, thank you again to all the presenters. Excellent information today. Really appreciate you taking the time to share it with this group. And thank you to the audience for joining us today. Our next SLP Grand Rounds will be on January the 14th, also at 8:15 a.m. We're going to have an interesting presentation on speech, language, and cognitive communication disorders that are of a functional nature, secondary to a neurological disorder. So again, that's January 14th. Hopefully you can join us. Until then, thank you again for attending SLP Grand Rounds. Bye for now.